Hey everyone, thanks for listening to the DNS Podcast. Today's episode is all about turning ideas into impact and what it really takes to bring something like indirect calorimetry from a grant proposal to day-to-day clinical practice. I'm joined by my friend and fellow DNS member, Anisha Chhibber. Anisha recently led a grant-funded initiative to implement indirect calorimetry at her institution. From purchasing equipment to developing policies and procedures, coordinating vendor training and educating interdisciplinary team members, to building RD competency, Anisha's work highlights how dietitians can lead meaningful practice change. Anisha is a clinical dietitian, fellow of the Academy of Nutrition and Dietetics, current treasurer of DNS DPG, and an experienced nutrition support specialist with a strong commitment to advancing practice through education, implementation, and leadership. Her experience spans clinical care, program development, and professional service, including active involvement with the Commission on Dietetic Registration since 2017. She's also a very active member of ASPEN, where she's contributed to the review and update of self-assessment modules and currently serves on the abstract review and enteral nutrition committees. Anisha has been recognized for her contributions to the profession and is deeply passionate about lifelong learning, interdisciplinary collaboration, and elevating nutrition support practice for all of us.
Coming to you from the Dietitians and Nutrition Support Dietetic Practice Group, this is the DNS Member Podcast, where we explore topics relevant to our field. From support line content to nutrition celebrity interviews and everything in between, this podcast is where DNS members can go behind the scenes and explore the driving forces behind cutting-edge nutrition support. I'm your host, Christina Rollins. Let's get started.
Well, Anisha, thank you so much for joining us today on the DNS podcast. I'm so very excited to talk with you about your project with indirect calorimetry.
It's a pleasure to be here, Christina. The honor is all mine. Thank you.
So what motivated you to pursue implementing indirect calorimetry at your facility? And what was the clinical gap that you were trying to address?
I think, I've been a dietitian, including India, for about 20 plus years now. And we've always, I'm sure during your time too, and many, many other clinicians, we've always, been taught and evidence is emerging even more since the indirect calorimetry is being used more at facilities, and there's more research that is coming out that the predictive equations are not the most accurate, neither are the weight-based nomograms. And I covered surgical ICU, where I have such a complex patient population, where I have patients with TBIs, spinal cord injuries, open abdomens, amputations, fistulas. So it's, it was always in the back of my mind that how, those equations, when we know that they are not accurate and they're usually between 40 to 75% accurate, how am I, are my predictions and my estimates impacting a patient's outcome? Mm-hmm. And I do a lot of lectures for the interdisciplinary team and surgical residents. And I had just actually finished a lecture with the residents, and the physician was just walking by and he said, "Oh, great job. Thank you for that." And I was like, you know what? For years, I've been saying IC is the gold standard, but we don't have it at our facility. And he's like, "We can get it." And I was like, "How's that going to happen?" He's like, "Well, let's apply for a mini grant." And I was like, "We have a mini grant?" And he's like, "Yes, we have a mini grant." And that's where our story started. It started in 2023 when I started doing all the literature review. And we'll talk about, what happened thereafter. And the practice gap was that, you have an objective tool that's available, and we're not using it, and we're still using those static, equations to estimate needs of our critically ill patients. And we know overfeeding and underfeeding have negative outcomes, be it the length of stay in the ICU or the vent days, or, patients developing pressure injuries and stuff like that. So I think that was my major motivation. And also it could be, XYZ might be using a certain equation, mm-hmm. and someone else would be using a different equation. So even though the ASPEN guidelines and Society of Critical Care guidelines and evidence analysis library from the Academy have guidelines available to us, still, clinicians use them in a different manner for the same patient. So just to standardize and to make sure, especially, for the morbidly obese patients or patients with ARDS and spinal cord injuries and TBIs, it made sense to explore this mini grant and try and implement an objective assessment tool in the ICU.
Well, I don't want to downplay all of the work that I'm sure it took to get to the point of applying for and receiving the grant. But once you had the grant and you had your equipment in hand, what were the practical steps required to move from, I have this great new piece of equipment, to actually using it for direct patient care?
Yeah, Christina, that's a great question. And I think post-COVID, there was a lot of research that was published on indirect calorimetry, and we had the DNS symposium in Baltimore and also the Aspen conference. I had attended all those great sessions from practitioners, and I connected with a lot of dietitians and physicians that use IC in their facilities. Mm-hmm. So I kind of had some idea as to, once I have the equipment, even before getting the equipment, I had organized a demo from the vendor for the interdisciplinary team, where we had all the physicians from surgical ICU, and nobody had seen all those physicians come in. So everybody was surprised that you really got all of us together. And I was like, yes, it took some, a lot of hard work and pushing and making sure I send those reminders. Mm-hmm. And then we had the ICU nurse manager, the clinical nutrition manager, the lead dietitian, respiratory. I had to have a, buy-in from them, because for the vent assessments, without their support, it's not feasible to do the study. So prior to even getting the equipment, I already had a kind of a working group in place. Mm-hmm. And I also had my nursing A&Ms and educators. So once we had the equipment, then it was all, getting to the competencies, protocol, policy. Though I developed the policy once we got the training, hands-on training from the vendor. Mm-hmm. And, it was all about the competencies, the policies. Infection prevention was a big, they were not included in the beginning, but one of the, physicians made sure that I included them. Mm-hmm. for the cleaning and the disinfection of the machine and the canopy. And then clinical engineering, of course. And I think those clinical engineering team is one of my, they're my best buddies now, because sometimes, the machine does act up and you have the vendor, but, I just have to call them and they're like, yeah, we're just coming up. We'll come and figure it out for you. Mm-hmm. So I think that, I was not sure that I would get the kind of support that I've had from the physicians and the interdisciplinary team at the hospital, but also from all the dietitians all over the US. Mm-hmm. I think LinkedIn has been my best friend. Mm-hmm. And like I said, connecting, it's always just try and ask, and you'll never know how many people are there to help you out. From mm-hmm. their busy schedules to Zoom calls to personal phone calls. I am still in awe of how so many people have helped me in this journey.
That's awesome. Well, tell us a little bit more about the development of your policies and procedures, and why was that step so critical for the long-term sustainability of this project?
Another great question, Christina. So when I had connected with the dietitians from other facilities, they did share their policies with me. And then we have the Aspen guidelines. We also have the Aspen core curriculum, the Academy's nutrition assessment pocket guide. So I did look at a lot of resources, as well as the published research that's available and literature, to come up with our policy, protocols, and competencies for the dietitians as well as the respiratory therapists. Mm-hmm. And our policy manager played a huge role in helping me with the policy. And we also had to actually then get it approved by our lawyer in the facility. Mm-hmm. So it went through a lot of steps. I had to present the policy to the ICU committee, which I had never been at. So there were physicians from, whether it was medical ICU, surgical, CCU, CVICU, they were all there. And I presented my policy, and then the ICU director had some feedback. And once we implemented that and refined the policy was right there. And the competency and protocols, the cleaning and disinfection protocol, I must say, was all from our infection prevention team. The vendor manual is there. They reviewed it, and what wipes are allowed at our hospital, and what we should be doing with the canopy, how to store it. They played a huge role in kind of guiding us through that piece. So I think we all worked together as a team, and then refined our workflows as we piloted the study in a few patients. Yeah.
So why do you think you were so successful with this project in pulling so many different disciplines? You mentioned the surgeons and RT and nursing, and these are a lot of people with a lot on their plates already. So why do you think that everybody was so drawn into this project and getting this off the ground?
I think like I said, I have been doing lectures on nutrition support, right? So they know, and I think a lot of it depends on your interpersonal skills, relationships. I think that's played a huge role in making this journey, bring it to where it is today. And they know that I'm very persistent. I think one word that I heard throughout this journey was, this was only possible because of Anisha's persistence. And I think my kids, my husband were also like, no, she's at this. This is her fourth child. Everybody at the hospital knows this is AC's IC, as they call it.
Nice.
So I think it's a lot. And they realize, once you show supportive evidence, you teach, you interact, they know it is precision nutrition and individualized nutrition support is where the field is moving towards. So we have to, if you're one of the top hospitals in the country, you have to adopt, a tool that is objective and that is evidence-based. I think they all realize that.
Now, how did you approach the education where you were presenting and teaching, but respiratory therapy was presenting their pieces? Like, where did kind of the pieces fall in that part?
So yeah, once we had our training in November and December, which was attended by nursing, respiratory, like I said, I did invite infection prevention. They were not able to come in, but biomedical staff was there. And he was there for the training too. So once the training was complete, I felt it was time that we all got to know a little bit more about indirect calorimetry, the device, what the tests are, how it improves patients' outcomes. And well, I did the didactic piece of it, but respiratory, because we are using, the vents for our vented patients, different types of settings on the vent, how the vent is, what is PEEP, what is FiO2, those kind of clarifications that made us also confident that, yes, I'm not a respiratory therapist, I'm a dietitian, but those settings on the vent and so what's happening with the patient, we have to coordinate with the respiratory therapist, because some days it's like, we're just looking at each other. They're like nodding our heads. Patient today? Yes. No. So we're all like, excited that we're doing tests. And, they're always, when they see the test, they're like, oh, Nisha, anything exciting about this one? Is this test okay? Our first test was the hardest test because it was the first one. And when I showed it to one of the physicians who had used this modality at his facility, he's like, Anisha, your first one had to be the toughest one. It was an underweight patient who in between got agitated, and, we had to kind of abort the test and do it the next day. And we got the REE, which made sense, but still. So I think the education from respiratory gave us the confidence that we know, what the vent settings are, what the different types of modes on the ventilators are. Because it is a collaborative study, right? So when, we have to check with nursing, is the patient going for any tests or anything, and then check with respiratory. And, if they think that the settings are too high, the numbers might seem okay to you, but they tell you, no, Anisha, I don't think you can do the test. The patient is just too agitated. So I think, interpersonal communication helps a lot. And this education, where I presented the nutrition piece of it, and the device and what it does, and respiratory presenting, the different modes and settings of the ventilators and how the O2 and CO2 kind of, come about. And, there is RQ that is calculated. I think that gave us as dietitians, and I invited the whole RD group, because as of now, just a few of us are trained. But everybody was there so that they also recognized that, this is a tool that is available in the ICU. And nursing was there. It was a virtual and in-person meeting. And I think it was well received by the interdisciplinary team.
So were there any challenges or barriers that you encountered along the way as you were moving toward implementation?
I think my biggest barriers were before the implementation, Christina. I think the hardest was getting those contracts signed by sourcing and legal. So I had to be on calls, and these are not clinical people, right? So I had to be on calls and keep sending emails, follow-ups to make sure that they were on track, because there was a certain timeline that we were trying to reach. And once that was taken care of, once we implemented the IC, I think every clinician faces those barriers where you've done the chart review, you're ready, respiratory is ready, and you think you can do the test, and then the rounds happen and they plan to extubate the patient. Or you've done a chart review before going up to the floor, and the patient is scheduled for the test, and the patient becomes septic or hypercapnic. Those kind of things happen where you're not able to do the test. But I think that was also a learning process where I told my lead dietitian, who's also trained with me, that these are all part of the learning. And at least we did a chart review. So tomorrow, if we have to do the test, we won't have to do a more detailed chart review. We know everything about the patient. We'll just look at the vent settings. We look at the other criteria that need to be met, and we'll do the test. We'll do the test tomorrow. So those were the barriers. And then again, hemodynamic instability was big. On paper or in the chart, they look different. And when you're up there, it's a different story altogether. And on spontaneously bleeding patients, now I started actually recording, keeping some data. I have a spreadsheet where, what are the reasons why I haven't been able to do a test on a patient, whether they're on high flow or they have dementia, or it's a C collar that is prohibiting that us to be able to put the canopy on them. So I think keeping that data is also giving me the confidence, where there are some days where I feel, oh my God, I've not been able to do that many tests. And then I have to, kind of say, no, you know what, you tried. And this is a very high acuity ICU. And you cannot get the perfect patient, but you also have to make sure that when you're doing the test on the patient, it's appropriate and it's safe for the patient. So that is something that we're realizing as we're, moving through this phase, where the real world is very different from guidelines and recommendations that are available.
Well, I think this is a great example of a dietitian advanced practice skill, which we know we have a lot of opportunity for advanced practice, as written in our standards of, scope and standards of practice. So as you honed in on your skills and expanded them, and now you're training other dietitians to do the same, how are you inspiring confidence while you're also building competency?
I think the biggest thing that we've done, Christina, is that we have limited the IC as of now to surgical ICU. The plan is also to move it to medical, but I've been very, slow in teaching, making sure that, I have a checklist, I have the policy. Every time I see a new research article that comes out, I'll share it with my colleagues. I made sure that we have a folder, which is a cloud folder that's available for the whole team. So it's shared with the interdisciplinary team, where I have articles, where I have the manual, I have all the protocols, policy, competencies. Even though our device, has pictures which tells you which tubing to connect, if you don't do a test for a few days, the respiratory will ask, Anisha, which one is going where? So I took pictures of, when we've done, obviously no patient identifiers or no patient per se, but where the connecting the tubings are. So all that is available. So every time anybody has any doubt, that resource is available where anybody can look up a study or like I said, the policy, the protocols, the checklist. I made a quick guide too, which has information on medications that impact energy expenditure, and the vent settings, how they impact and some troubleshooting guide is there, which I was assisted by another dietitian. And again, it's all, I think, support and guidance from clinicians who are actually experts in IC. And I'm very fortunate that they are now friends. And every time I have, a doubt or a clarification, yesterday itself, I texted a dietitian. I'm like, I need some literature on medications that impact energy expenditure because I'm seeing that in some of the patients that it is impacting. And I got up today morning, I had that email where I had all the references from her. So I think that keeps me motivated and making sure that, when as of now, I've trained one more dietitian. The lead dietitian was trained during our training in 2024. And on March 3rd, we'll complete 1 year of IC journey in the surgical ICU. And I plan to train one more dietitian. But like I said, we've kept it slow, introduce them to the interdisciplinary team, introduce them to the, because for the canopy, the parts have to be disinfected in the disinfection room, sorry. So, introduce them to that, then do the tests. There's a competency which has to be built, make sure they read and review all the literature that's available. So I have tried to, not put any pressure because this is something that we're doing while we're seeing our patients too, right? So I have my productivity where I have a list of patients that I'm seeing. And if I'm doing a couple of tests, someone will help me out, take another patient so that pressure is not there. So we're working as a team to make sure that, the beginning, a test took me like an hour plus. And the other day I was done so quickly and interpreted. So every patient is so different. And the assessment and the interpretation is, you learn. The more tests you do, the more complex the patient, the more you think, use your critical thinking skills, the more you learn and the more you can teach. So I think that's the approach that I have followed, which has worked best in our favor, is let people take their time. There is no timeline per se. You want to see me do more assessments, you're most welcome. But if you think you're competent enough, let me see you do one. And let's interpret. And we share. If I've done an assessment, I always like take feedback. I'm like, hey, can you check, see, does this make sense? You think I'm increasing the tube feed, decreasing the tube feed. So I think that interaction with each other also gives us the confidence that, because we're all still learning. And I don't think I will stop learning because every patient gives me something new that I need to research and learn about.
Well, and I understand that you've taken it one step further. So you're not just focused on your own institution, but now you've written abstracts and you're working on these scholarly submissions. So tell us a little about that and why did you decide to take it to that next level?
I think when it's a journey, right? And it's a roadmap. So we have the guidelines from different societies, but there is no definitive roadmap or a protocol that's available that another institution can follow. So my thing was, if we have this journey, why not share this journey? So that is when I decided to present our abstract to Aspen 26. And it was last week that we presented our poster at Aspen. So it was just a means to share, because I'm sure, just like us, there are many institutions and clinicians who want to acquire and implement this tool in their facility. They just don't know how to do it. So I think our roadmap may be, something that others can utilize and tailor to their own institution. So that was my biggest, I think, motivation, was to share this journey with clinicians and other facilities. And I already have 3 facilities that are in touch with me to see how best they can acquire and implement this tool in their facility.
Well, and I know that you're also exploring other research opportunities related to indirect calorimetry in the SICU population. So how do you see clinical implementation, research, and education all sort of intersecting into this space?
Yeah, I think they're all intertwined, right, Christina? Because when we're doing tests the other day itself, one of the dietitians was like, I think this predictive equation has been pretty close to IC. So, we are generating more, questions. And those questions are resulting in maybe some research that we want to do. And that's what my plan is, that I'm trying to come up with a study design with our research physician on TBI patients.
Mhm.
So, because that's a patient population that we see most in surgical ICU, and those patients are, metabolically very complex, and their needs can vary from 140 to 200 to even more %. So, once you are at the bedside doing these tests, you want to be able to validate what you're doing and further refine your protocols and what you've been assessing patients. So I think application and research, that's how they come together.
Mhm.
And once your research is, published and, and it's disseminated, I think, you're educating yourself as well as other clinicians and dietitians on IC and the patient populations that they serve. And it also gives you an opportunity further to learn and educate based on your research.
Mhm.
All three of them are like braids, strands of the same braid, I guess.
Mhm.
Yeah.
Well, we're almost out of time, but I'm excited. I want to share that DNS is actually offering some research funding available. So we have a research stipend of up to $10,000 that can support our members in research endeavors like the one that you've been on, for the past months to years. So the deadline is coming up soon on April 1st. So what advice would you give our listeners who are working on, or hopefully now hearing about your project, feeling inspired, and can maybe think about submitting an application for the research grant with DNS?
Yeah, that's a great grant. And like Christina said, it's due on April 1st. And, I'm telling you, the data is sitting there. There are pilot studies, there are QI initiatives that are all right there. You just have to motivate yourself and find a mentor, whether it's somebody from your own facility or a dietitian from DNS or anybody else, who's great at research, who can help you and assist you with this project. Because you never know, a small pilot study can result in, further publications and more research. And that's what I would motivate, is apply for this research grant from DNS. And it's a great opportunity to showcase your hard work and to disseminate all that you've been doing. And like I said, maybe even if it's a little frustration of yours where you want something to get, something to improve, it could be a QI project or something that is, a retrospective data that you have, and you start reviewing that and apply. It's a month is there, and it's a great way to make sure that you can showcase your research, your QIs, your pilot studies, which can result in many more collaborative work with clinicians from your own facility or from other facilities.
Awesome. Well, thank you so much. And congratulations on your recent presentation, Aspen. I'm sure it was amazing. So I think this story is it's such a great example of advanced practice for dietitians, and you're doing an amazing job. So thank you so much for sharing your story.
Thank you so much, Christina, for having me on the show. Thank you. Take care. Bye-bye.
And listeners, be sure you check out our website, dnsdpg.org. You can network with amazing dietitians like Anisha, learn about other project ideas, and of course, you can apply for that mini grant that's coming up due on April 1st. So check it out at dnsdpg.org. Until next time, I'm Christina Rollins. Thanks for listening.